Good morning. I'm Susan Denser, Editor-in-Chief of Health Affairs, and let me welcome you to our briefing on the release of our November-December issue on medical technology. This is a thematic issue that we produce with the support of the Blue Shield of California Foundation, as well as with two private companies involved in medical device research and manufacturing and sales, Medtronic and Johnson & Johnson, and we're grateful to all of them for making this issue possible. Medical technology is one of the most important, if not the most important, drivers of rising health spending, as we know, and it's clear that this technology is producing innumerable benefits for all of us. This issue of Health Affairs focuses mainly on two forms of technology, imaging and devices, although we also have some very important articles on genomic medicine, as you'll see. If we stop and think for a moment, it's impossible to imagine where we'd be without many of these advances. Thanks to imaging, obviously, we can find out in a matter of seconds in a very non-invasive way whether the underlying cause of a seizure is a brain tumor or something far more benign. We can find out whether a person experiencing angina has a blockage that requires treatment or something much milder that may be amenable to much less invasive diagnostics and therapy. Even laying aside some of the safety concerns we've seen in recent years from some medical devices, we know they're producing benefits, preventing deaths from cardiac arrest due to life-threatening abnormally fast heart rhythms. We can use cardiac defibrillators, these small electronic devices that can stay in the heart, stay inactive when the heart is beating normally, but when an irregular rhythm develops, sense that and deliver a tiny electric shock. So we know we're getting benefits out of this, and we've published a survey in this issue that shows that the public is obviously very supportive of these advances in medical technology, with 9 out of 10 adults linking advanced technology with high-quality health care. Yet, as I mentioned in my editor's note in this issue, you cannot help but read through all of these papers and think about some of the possible parallels to the financial system meltdown we've experiencing in recent weeks. Now, just as lending lots of money to poor people who couldn't afford mortgages in the interest of broadening home ownership and giving them a boost up the economic ladder once seemed like a very good idea until it got out of control, you have to wonder whether we're seeing any parallels in medical technology. As we'll hear this morning, each new CT scanner that came on the market in the U.S. from 1995 to 2004 was associated with more than 2,200 additional images per year in the Medicare population alone. Now, how many of these scans were truly value added, and what was the value added, it's probably impossible to say. When we shift over to medical devices, we see additional concerns. Economics identifies the concept of an oligopoly, a market dominated by a relatively small number of participants who are able to collectively exert control over supply and market prices. And with all due respect to some of the corporations who help to fund this issue, according to some of the papers we published, that appears to be what we have in much of the medical device market. In this issue, Mark Pauly and Lawton Burns write about how these few producers charge very different prices to different buyers, and then write into the sales contracts and enforce confidentiality clauses that bar these purchasers from sharing transaction prices with each other, and in some cases, even discussing these prices with the doctors who will use the devices. The firms then focus their marketing efforts on physicians. And as Jamie Robinson notes in his paper, they sometimes grant the doctors stock options and fees that may actually exceed what the doctors earn from clinical procedures. Now, we have panel members here today who are prepared to explain to all of this why, in the end, this is a great benefit to society, and we look forward to hearing that. And we also have panel members who will take quite the opposite view. And of course, as some of you know, legislation has been introduced into the Senate by Republicans Senator Chuck Grassley and Arlen Specter that would bar these contract clauses that block price transparency. Now, of course, the big picture here is whether or not we're obtaining so much value out of all of this technology that it is absolutely worth paying every dollar for, and paying for it to the exclusion of other things that we as a society might want to invest in. So after we hear from our presenters this morning, I hope we'll delve into those big picture questions and have a very vigorous discussion among our panelists and those of you in the audience as well. Let me introduce our panelists to you now. First, we will hear from Laurence Baker, PhD. Lauren, you raise your hand. Okay, who is a health economist and professor of health research and policy at Stanford University. He's also chief of health services research at the Stanford School of Medicine, and he's been appointed fellow of the Stanford Center for Health Policy and a research associate of the National Bureau of Economic Research. He studies a variety of healthcare economics and policy questions, including the effects of financial incentives and organizational structures on healthcare delivery and health spending. After Lauren, we'll hear from Jeff Lerner. Jeff, raise your hand. Give him that old Queen Elizabeth wave there, who is the president and CEO of the ECRI Institute. Now, ECRI is a name like AARP. It used to stand for something. In the old days, it was Emergency Care Research Institute, since it started when a little boy died in a Philadelphia hospital emergency room because of an improperly maintained defibrillator many years ago. But in the years since, it has evolved just into ECRI Institute, and its scope has widened. And now it is an independent nonprofit that researches the best approaches to improving patient care in terms of safety, quality, and cost effectiveness, including assessing clinical procedures and drug therapies in addition to medical devices. After Jeff, we'll hear from Hal Singer, who's president and managing partner of Empiris, a private consulting firm that offers expert economic, financial, statistical, and management consulting services to clients engaged in litigation, regulatory proceedings, public policy debates, and so on. His areas of economic expertise are antitrust, finance, and regulation. He has published scholarly articles in more than 25 economics and legal journals. Excuse me, he's a frequent speaker and editorial writer as well, including having written columns in several leading newspapers such as the Wall Street Journal and the Washington Post. And then finally, we're also very happy to have with us David Nexon, who's Senior Executive Vice President of the Advanced Medical Technology Association, or AdvaMed, which is the trade group representing a number of medical device and other medical technology manufacturers. David is responsible there for domestic policy. Before joining AdvaMed, as many of you will know, he served for more than 20 years as the Democratic Health Policy Staff Director for the Senate's Health, Education, Labor, and Pensions Committee, and as the Senior Health Policy Advisor to Senator Edward Kennedy. So welcome to all of you, and Lauren, I believe we'll begin with you.
Well, thank you. It is a pleasure to be here to be able to talk about some of the work that we've been doing. I've been working on this particular paper with a couple of colleagues, Scott Atlas from Stanford University and Chris Affendoulis from Harvard, and we're happy to have been funded for this by a grant from InHealth, and really happy to have this appearing in the current issue of Health Affairs. This paper starts with something that I'm going to hazard a guess that most of you have heard before. We have put in loads of new CT scanners and MRI equipment over the last decade or so in the United States, more than 3,000 new CT scanners, more than 3,000 new MRI scanners since 1995. And along with this has gone dramatic increases in utilization. The bottom figure up there, it's kind of small from where I'm standing at least, shows the upward sloping graph, the upward sloping line associated with increasing CT utilization in the Medicare population in the blue, and upward sloping line trend in the use of MRI procedures among the Medicare population. CT goes just in the last decade, in the decade between 95 and 2005, from about 200 per 1,000 Medicare beneficiaries to almost 600 per thousand Medicare beneficiaries. MR goes from maybe 30 or 40 up to about 200, so dramatic increases even over a 10-year period. Shockingly, increases in utilization and increases in availability are related. Here are two graphs. Again, kind of small, but the gist of it is each one of those has about 318 dots on it. Each dot is a city. And on the horizontal axis there is the change in the number of scanners or pieces of MRI equipment. And on the vertical axis is change in utilization in the Medicare population. An upward sloping line. The places that put in the most scanners over the decade, 94 to 2004 in this case, you had the largest increases in the number of procedures. If you do some statistics on that, you'll get the number that Susan was citing a minute ago. Each new CT scanner that we put in this data is associated with about 2,500, 2,200 to 2,500, depending on how exactly I do the calculation, new bills to Medicare for CT procedures, and every new MRI scanner is worth about 800, or is associated with about 800 more bills to Medicare. Now, Medicare is only one payer. Medicaid and private insurers will also be getting bills for these things, and so there's dramatic increases in utilization, and along with that, costs that are associated with each new piece of equipment that we put in. Now, those statistics have been out and around in different forms over time, but what they do really is tee up what is probably the fundamental question here, which is the question of value. Are we getting the kinds of benefits from these, from expanding availability that would be commensurate with or offset the costs associated with it, such that we can feel good about the kinds of expansion we've been seeing? Do we need to focus in particular places where we get high value? And if we do, how do we understand that calculation? How do we begin to make policies, to make decisions in ways that will make our healthcare system efficient? And as we argue in the article, it seems that this, in imaging in particular, this is a complicated discussion because there are at least two major classes of benefits that you could get. One of them is maybe the classic better health outcomes. If you can substitute newer imaging-based diagnostic testing for older, maybe more invasive, maybe more side effect prone tests, perhaps you can improve patient health outcomes by having fewer problems associated with imaging. Maybe you can get better information, faster information, more information from imaging than you used to be able to get from older tests, and that might lead to better therapies and better treatments that ultimately make patients better off. And so you could construct an argument that there is a potential class of benefits that are associated with better health outcomes in the way that we often argue is a key driver of benefits in the healthcare system. But in the case of imaging, and in the case of other technologies as well, there's another large class of potential benefits, and we call that the value of information and other intangibles. In some cases, maybe a patient goes to the hospital, goes to see a physician, says, my knee hurts. The doctor says, well, wait a few weeks, and we'll see if it gets better, and if it doesn't, then we'll do something about it. Another case, maybe you go to the same doctor, different doctor, and they say, well, let's get an MRI scan right now. The MRI scan shows, well, your knee will probably get better in a couple weeks if you just sit and rest it. Ultimately, the patient doesn't get any different treatment. We rest the knee for a couple weeks. Ultimately, they end up with the same health outcome, but now they have some additional information. They know something a little earlier than they would have known it before, and maybe the value of the information creates some benefit for the patient. You can also make the same type of you can make another argument about benefits from intangible sources in the sense of convenience. Maybe you would have gotten a biopsy before there was imaging available. Maybe now there's an imaging test. Biopsies are annoying. They hurt, maybe they take scheduling, they take time, and maybe imaging is faster, less invasive, less troublesome. So even if health outcomes are the same, patients might benefit because of more convenience, because of more satisfaction. And so there's a class of intangible benefits that come potentially with imaging as well. Now ultimately we want to take these two sources, general sources at least of benefits, and compare them with the impact of expanding availability on costs, and now you get a complicated discussion. What do we argue in the article? Well, we argue that impacts on better health outcomes, expanding imaging, creating better health outcomes is probably an important source of benefits. We do in a little example in which we talk about the diagnosis of abdominal aortic aneurysms and suggest that there is some reason to believe that better diagnosis there can lead to actual better health outcomes. But ultimately, this is an area in which we know very little in the context of the broad expansion of imaging that's going on. We've moved far beyond the areas of clinical trials in which particular patients and with particular conditions have been studied to using imaging in very broad populations in a very quickly evolving setting. And so we probably know only a small fraction of what we need to know to really understand the benefits that come from expanding imaging. And we get into even more trouble when we start talking about the value of information and other intangibles. As we argue in the paper, this is probably at least as important in some cases, maybe more important than the value of actual improved health benefits. In the example that we work on in the paper on abdominal aortic aneurysm diagnosis, this is probably the largest group of patients or the largest source of potential benefits, but understanding how large those benefits are is a very difficult problem. We simply don't have the information to make reasoned concrete decisions about this. So where do we go in the end? The paper suggests, and I think what we need to start thinking about, is confronting the challenges of technologies that generate benefits other than changes in health outcomes, I should say, on the slide. This is in some ways the fundamental question that is confronting the U.S. healthcare system. We have, for a long time, paid for a lot of healthcare technologies and healthcare treatments that make us happier, even though they don't always make us demonstrably, objectively healthier. and understanding how we will deal with that going forward is an interesting question. If we have the money to pay for that at some level, there's no reason that we shouldn't do it. As budgets get tighter, we need to start to think about these issues maybe more acutely. We may need to think about coverage approaches that recognize the challenges here. How do we want our institutions in the healthcare system to think about benefits from different sources? Would we like to recognize differentially benefits from information, benefits from intangible sources, and benefits from health outcomes? If we want to recognize them differentially, how do we do that? And to what extent do we want to incorporate, say, or incorporate these kinds of things into payment policies? And fundamentally, we need to collect information and continue to be monitoring, watching, and vigilant in this area so that we can improve our understanding of value of information, of intangible benefits in imaging, and we can start to think about collecting broader health outcome data for imaging as well. So I want to stop. I think I've probably used up my 8 minutes or something like that, and say that I hope this tees up some issues, and I'll be delighted to discuss them with the panel and with you all as we go forward from here.
Great. Thank you, Lauren. Jeff.
Thanks very much. This first slide is just to orient you to where in the journal you find this, the piece that I wrote with my colleagues and the subheads. In recent years, some manufacturers of some very important, expensive medical devices, such as artificial hips and knees, implantable defibrillators, and pacemakers, have been restricting their hospital customers from sharing information on prices they pay. These devices are collectively known as physician preference items. Hospitals may not share this price information with physicians, consultants, attorneys, other hospitals, or third-party aggregators of data that post prices so that brands and models can be compared. My nonprofit research institute is one of these data aggregators. These manufacturers have placed restrictive clauses, referred to as confidentiality clauses or secrecy or sometimes as gag clauses, in their contracts with hospitals or on invoices or other purchase documents. Legal action has taken place with third-party aggregators of data. These manufacturers claim that commercial law supports their ability to keep prices secret. We believe there's a strong public interest in transparency, we being me and my co-authors. We believe legislation is necessary to clarify this issue. There's a bill before Congress to make prices transparent so that buyers can compare them. If market data on prices paid becomes less and less available to purchasers, it greatly expands the overwhelming asymmetry in information held by sellers versus buyers. Every medical device salesperson already knows his or her competitors' prices, and the companies they work for have a great deal of price information now. Please keep this in mind when you hear the next speaker. This movement towards making prices secret comes at a time when much public policy aims to create exactly the opposite: transparency of information about cost and quality. The medical device industry is about $112 billion per year, and according to Senators Grassley and Specter, about 60%, or $60 billion, are physician preference items. Hospitals, said Senator Grassley, have no way of knowing what a fair market price is, because in this one industry, there is a veil of secrecy over pricing information. He said hospitals are involved in one-sided negotiations with manufacturers, and, quote, many hospitals pay absurdly more than others for the same medical device, unquote. One hospital may pay $5,000 more for the same device. Both the senators and we contend that hospitals should be allowed to access information on prices paid so that they can effectively negotiate the best deals with manufacturers. Hospitals want comparative information because it's useful. Some manufacturers oppose this because it works to bring down prices paid. It's an effective tool in negotiations. You don't need to rely solely on the salesperson who assures you you are getting a great deal. And after all, everybody can't be getting the great deal. Price is not always linked to the volume of goods purchased, despite the claims of some manufacturers and beliefs of some trusting buyers that there is a strict linear relationship between cost and volume. Prices for physician preference items have been rising. Here is an example. Between 1996 and 2006, the price of total hip implants more than doubled. Costs will continue to rise. For example, the more expensive models of devices are being used ever more frequently. So in other words, the more expensive hip implant than the cheaper implant. Also, the number of procedures performed is rising rapidly, and far more rapidly than predicted among Medicare and private pay patients. These costs weigh on hospitals. One large urban hospital, cited in our article, spends $65 million a year on implantable devices. That's 40 to 55% of their supply expense. One of my co-authors, who is CFO at a rural medical hospital in Iowa, spends $3 million, or 40% of his budget, on supplies on these devices. The director of CBO says that half the increasing cost of healthcare is accounted for by technology. Doctors Burns and Pauly, in this issue of Health Affairs, explain many of the dynamics of purchasing for physician preference items, and I imagine we'll be discussing these later. But my fellow authors and I contend that transparency supports effective negotiation in this field, just as it does in nearly every area of the economy. If you were seeking to purchase a house, you would be able to learn the last price paid for that house and the prices of comparable houses. If you were seeking to buy a car, as Secretary Leavitt says, you would be able to find information on price and quality from Consumer Reports. A website and phone service from CMS allows you to compare the cost of Part D drug plans, offering your specific drugs. The fact is, you can hop on the internet and compare the price of nearly anything. Senators Grassley and Specter introduced a bill, the Medical Price Transparency Act of 2007, which has these basic characteristics. Manufacturers would report quarterly on the average and median prices of implants. These prices would include all of the extra free goods and services that get bundled into the price, and discounts, such as rebates. The information would appear on the web. I think we can assume that this legislation will have teeth, and if companies use the information to collude, as Dr. Singer fears, they can be punished. The public policy question before us is whether to allow some manufacturers in this key segment of the medical device industry to tie Adam Smith's hand, the invisible hand that makes capitalism work, behind its back. Medical care is complicated, and that'll come out in our discussion. But let's not forget the fundamentals. If you can learn the price that others pay, you can negotiate more effectively. If you cannot learn the price, you will be in the dark. Whether the senator's bill, as currently constructed, is the best approach can be debated. There are alternatives, such as banning the imposition of confidentiality clauses in contracts between manufacturers and hospitals that wish to participate in the Medicare program. But whatever option is chosen, please keep in mind this thought. Hospitals are buying on behalf of the public, on your behalf. Should they be prevented from doing this by an assault on transparency? A short while ago, Alan Greenspan told Congress he was disappointed that industry didn't regulate itself. If this market for physician preference items is to be a functional one, legislation will be needed to permit appropriate market forces to work on behalf of the public and on behalf of the healthcare system. Thanks.
Thank you. All right, Hal, not to up the pressure on you, but now tell us why all of this is really a good idea for society.
Hal's planning to thank me.
After that warm introduction, I don't know if you should believe anything that I'm going to say now, but I want to thank Health Affairs for putting this on, and also thank my co-authors, Bob Hahn of the American Enterprise Institute and Keith Clovers of Empiris. This is actually the second time that I've presented this paper at the Press Club. The paper has spawned two reply articles, one by Jeff, another one by Pauly and Burns, and Health Affairs has nicely put together the papers in a package so that you can see both sides of the debate. And hopefully after this speech, you'll come down on the side of truth. You also see why economists, by the way, like myself, aren't invited back to cocktail parties. You know, we're always poo-pooing very popular, in this case, populist ideas. I'll let you be the judge at the end. So our approach here is to look at how mandatory price disclosure has fared when it has been applied in other industries. It's kind of a common approach of economists. We're trying to find the success stories. There are few. And we're trying to find the failures. There are many. Trying to see what are the ingredients that makes mandatory price disclosure work. What are the ingredients that make it fail? And then we try to apply those lessons to the healthcare industry. Now, if you read the longer paper, we have a long paper, which is the white paper. That's how it all began. And then we have a shorter paper that ran in Health Affairs. You can go through many of these case studies, and I'll just take you quickly through some of them here, but you'll get the gist of it. We have a cement case, a rail rates case, and a long-distance telephone case. And there are many more in the economics literature, and maybe economists just have a thing against a mandatory price disclosure. But in general, they seem not to work. In general, there are occasions. We can find occasions where they do work. But in general, they don't. And let me just tell you about the FCC example, because that one's near and dear to my heart. In each of these cases, by the way, cement, rail rates, and long-distance rates, after mandatory price disclosure was imposed, it was quickly repealed when the governing body recognized that it was facilitating collusion among the suppliers. So in the FCC case, I just want to quickly tell you the story. This started in the mid-'80s, and it was repealed in the early '90s. But by 1993, AT&T was charging 23.5 cents per minute for long distance. MCI was charging 23.4 cents for long distance, and Sprint was charging 23.5 cents for long distance. They were each taking advantage of the FCC's mandatory price disclosure rule that compelled AT&T to post its prices to a government website. As soon as the FCC figured out what was going on, they repealed these rules. And I think the important lesson here for everyone is that identical prices should not be the goal of public policy, especially when they are identical and higher. So how do economists think about the costs and the benefits of mandatory price disclosure? Well, what we're trying to do is identify the conditions. Let's start off with the benefit side of the ledger first. We're trying to identify the conditions under which the benefits from mandatory disclosure are large. These conditions came from the literature. We did find occasions in which mandatory price disclosure in other industries worked out, and we wanted to see what those cases had in common. And so we were able to come up with these conditions. You can see the conditions. The most important one, of course, being that search costs are high. But all four of these conditions are necessary. It's not the case that if you just show that one of them is satisfied, then it necessarily means that mandatory price disclosure is a good thing. Let's start with the one about big variation in prices. Well, my fellow panelist here, Mr. Jeff, says that he in his article that only 20% of the variation in implant prices can be explained by volume discounts. Well, that's a very fair point. But my counterpoint is that if the remaining 80% of the variation could be explained by other discounts, non-volume discounts like bundled discounts, which we can talk about, or loyalty discounts, if the variation can be explained by discounts, other discounts, then no amount of price disclosure is going to remove that price variation. So then we do the same exercise on the cost side of the equation. We want to see what are the conditions under which the cost of imposing price transparency are large, and we want to see if those conditions are satisfied in this industry. I think the most important idea here is that mandatory price disclosure has been shown to facilitate collusion in other industries. And so we want to ask, and just following right out of the Department of Justice's guidelines, what are the conditions in an industry in which price collusion or price coordination is easier, all things equal? And these are basically those conditions. So let's start applying now the conditions for the benefit side of the equation. And like I said before, the most important one probably is concerned search cost. But we think this first condition, which is vital to making a case for mandatory price disclosure, is not satisfied. And here's why. To understand the price formation process in the medical device industry, you have to understand the GPO bidding process. So if you will, let me just take a few seconds explaining.
And GPO, for those who do not know, is Group Purchasing Organization.
Yes, Group Purchasing Organization. I presume that all of you guys know more about the healthcare industry than I do. This is important. 80% of acute care medical device purchases are made pursuant to a GPO contract. So the vast majority of purchases that we're going to be discussing today are governed by these contracts. Now, the GPOs act as a buying agent for the hospitals. Okay, and here's how it works. The GPOs conduct essentially an auction, and all the suppliers of a particular device come up to the auction and they submit their bids. And their bids include all the devices they make, all the price schedules, and all the discount schedules that they're willing to offer. At that point, the GPO picks 1, 2, or 3 winners based on lots of things, including the price. And at that point, the member hospital chooses whether or not to buy at favorable prices for one of the GPO-selected products, or at unfavorable prices for one of the non-selected products. Now, mandatory price disclosure is being sold here as a way to reduce the search costs for the hospitals. But what I'm trying to explain is that the hospitals aren't the ones who are imposing the price discipline here. The price discipline gets imposed at the GPO bidding process, and the GPOs have all the information they need to play these suppliers off each other. And remember, during that process, each of the bidders submits all of their prices on all their devices, and then the GPO decides which one is going to win the bid. Let's move now to the second condition, which we also believe is not satisfied, and this is the notion that telling the suppliers that they're going to have to post their average prices to a government website is going to do something to affect the pricing process. It won't. As Burns and Pauley, who, by the way, support this bill, admit in the same in the Health Affairs article, they say that giving out averages prices aren't going to do anything. You're going to lose all the information relating to the discounts and the causes of those discounts. So as we work our way through, we also find that the third and the fourth conditions are not satisfied. I'll just try to go quickly here. On the fourth condition, we talked about the existence of some price variation. Doesn't imply that price disclosure is going to eliminate that variation. I can just tell you from my personal experience studying prices in medical device industry, we can explain nearly 100% of the variation in the prices that hospitals pay based on just knowing what GPO they bought under and what tier of the GPO contract they bought under. Bargaining position of the hospital, which is this notion here that underlies the idea of empowering hospitals to make better decisions, in my experience, has no effect on the prices that are paid, and here's why. The medical device manufacturer typically imposes what's called an MFN, or a most favored nation contract, provision into the GPO contract. And what that says is that if I cut you a special deal, I have to go back and give the same deal to every hospital that bought pursuant to that GPO contract. And so whenever you call up the supplier and you say, pretty please, or respect my bargaining power, give me a price cut, you're going to hear this MFN provision thrown back in your face. And at the end of the day, it's a big waste of time because you're not going to get that discount. I'll also, we'll talk about the role of physician preferences later, just so that we can kind of speed things along. Quickly, we move now to the cost side of the ledger. And we think here, unfortunately, that the conditions that would imply that mandatory price disclosure could impose large costs, appear to be satisfied. This industry has the right conditions so that if you arm the rival suppliers with each other's prices, bad things could happen. It's highly concentrated. There's just a few suppliers for each device, and the other conditions are satisfied as well. So I'll just move to the conclusion now. I mean, at the bottom line, we're open to the possibility that mandatory price disclosure could make sense in some industries, but before you jump to policy, you want to make sure that the benefits exceed the costs. And in this case, we just don't think that the conditions are right for there to be net benefits to society. Thanks.
Great.
I'd like to start out by thanking Health Affairs for devoting an issue to our industry, and thanks, Susan, for inviting me to participate. I'd like to before I get into sort of the meat of this, my piece of the discussion, which is on this issue of price transparency, I'd like to make a couple of more general points. First of all, I wanted to introduce you just a little bit to the Advanced Medical Technology Association, AdvaMed, which I represent. We're the largest medical technology association. Our suppliers produce medical devices and diagnostics. It includes things like advanced imaging equipment, artificial hips and knees, cardiac implants, surgical tools and devices, tongue depressors. Virtually anything that's used in medicine that isn't a health professional or a drug is manufactured by our members. The second point I'd like to make goes, I think, to some of the points Susan made in her introduction. Medical technology writ large, not our industry specifically, but us, the drugs, really medical progress, new surgical techniques, and so on, is under an awful lot of assault these days, I would say. There are two ideas that are being endorsed by many health policy analysts. The first one is that medical technology is the driving force behind excess increase in healthcare costs. And the second is that the best way to control healthcare costs is to control or ration medical technology, the development of new treatments and cures. I think both of those are false, the first one partially so, the second entirely so. I won't have a chance to discuss it in detail during this presentation, but I certainly welcome the opportunity during the question situation. I do want to emphasize, though, something to sort of a frame around this whole issue of medical technology, and that's something Susan alluded to, which is the value that medical technology brings. It's easy to see it in terms of individual products, but I think people are less aware of sort of the overarching economic case for the value of medical technology and of the human impact overall. This chart comes from a study by William Nordhaus, an economist at Yale University, where he essentially was trying to estimate the economic value of the increases in longevity that we've experienced over the course of the past century. And those increases in the latter part of the century was certainly due primarily to medical progress, really treatments and cures. And what he finds is quite striking. He finds that the value of medical progress is roughly equivalent to the value of all the other increases in consumption we've seen over this 100-year period. All our advances in income, our better housing, our cars, our automobiles, our computers, all of those put together are just about equal to the value that we've gotten from medical progress. You can also see this in sort of the human side of how it affects individual patients and their families. This is in the last 1980 to 2000. Life expectancy increased 3 years. Disability amongst the elderly declined 25%. Mortality from heart attacks was cut by 50%. Mortality for stroke was cut by 1/3. Mortality from breast cancer has been cut by 20%. Now, I give you these statistics not to say that everything about the medical technology industry is right, not to say that there shouldn't be reforms in many aspects of our healthcare system, but I think it's terribly important to recognize that even as screwed up as our overall healthcare system is, its fragmentation, inability to manage chronic disease, lack of primary care, lack of focus on prevention, all those things were going on during this period, but despite that, we had these marvelous increases in people's well-being and health, really, because of medical progress. And we're now in what many have called the age of the life sciences, the century of the life sciences, where we're seeing in the life sciences and the biological sciences the kind of leaps forward in fundamental knowledge that we saw in the last century, which people refer to as the century of the physical sciences. And as we look at health policy, I think it's terribly important that we recognize the immense opportunities for progress we have and make sure that public policy doesn't have the effect of squashing or limiting that progress. If I can move on now to the particular issues of this question of price transparency, just a little background. Our industry, not technology as a whole, but our industry, medical devices and diagnostics, many people may be surprised to know that we're over a 14-year period, we're a rather small proportion of total healthcare expenditures in the United States, varying between 5 and 6% over that 14-year period, despite all the advances in new technologies that's come online during that period. Not only are we a relatively small proportion of total expenditures, but we're a relatively constant proportion. It's been between 5 and 6% throughout that period. If we look at prices, and this gets me to the issues that were raised by the last two panelists, I'd like to begin first by making a comment about this whole issue of confidentiality of contracts. People should understand, and I don't think many people do unless they've had occasion to get involved in this, that this idea of a confidential contract between a purchaser and a seller is not unique to the medical device industry. Indeed, when you're talking about relationships between two businesses, automobile manufacturers purchasing spark plugs from a supplier, a drugstore purchasing supplies from a Johnson & Johnson. I mean, throughout the American economy, when you're not talking about sales directly to consumers, which is the case for most medical devices, confidentiality clauses in contracts are the rule rather than the exception. So the idea that there's something strange or sinister about them in the medical device area is simply wrong. Now, in terms of the proposal to provide for greater transparency of medical pricing on specific items that's been espoused by one of our speakers today, by Jeff, the fact is, in my view, it's a non-solution to a non-problem. It's a non-solution for the reasons that Hal has laid out. It's a non-problem because if you look at the facts of the industry, it's a highly price competitive industry where the performance in terms of price has been better than virtually any other sector of the healthcare economy. This is a study done by Guy King, the former Medicare actuary, looks at prices, increase in prices for medical devices over a 15-year period. Not only are we less than the MCPI, the prices for other medical goods, but we've grown half as much as the general CPI. I doubt there's another sector of the healthcare industry that you can make that statement about, and that's because we are a highly competitive industry. This chart is another way of showing that. It shows a somewhat more disaggregated look at different types of medical devices and compares it to hospital prices that they charge to purchasers of hospital services. And you can see that in all three cases, our prices have gone up substantially more slowly than hospital prices overall. Let me apologize. There's a mistake in the labeling on this slide. The first line is correct. The price increases for general medical and surgical hospitals. The second line from the top should be surgical appliances and supplies. The third line should be surgical and medical instruments. And the fourth line should be electromedical apparatus, which includes things like imaging and implantable defibrillators and so on. And Susan, perhaps I can get your corrected version if you're going to post these later. This slide makes really essentially the same point. It looks at sources of hospital cost growth. This is from the hospital industry itself, from the AHA. And they looked at why are hospital costs growing between 1998 and 2003 over a 5-year period. 43% of that growth was the cost of goods and services purchased by hospitals. We're obviously in that category, our products. What happened when the hospitals broke down that 43%? Well, we were so small, we didn't even merit our own little bar on the pie chart. We're buried somewhere in that 8% down at the bottom for all other. And the reason that's so is if you go back to the previous charts, we're actually growing much more slowly than hospital prices as a whole. So if anything, we ought to be kind of a minus taken out of that 43% rather than a wedge, and that's why we're not shown as a source of hospital cost growth. So I think I've probably exhausted my 8 minutes. Let me stop here and just say once again I'd like to emphasize the value of medical technology and thinking of when we think about public policy, we have to think about it in the context of that value and avoid to do anything that's going to detract from it. And on the issue of price transparency, which is really a very small part even of the issues of cost around medical technology, it's really, in my view, based on the data I've presented to you, a non-solution to a non-problem. Thank you.
Thanks, all of you. Let me also mention that we have at least one other author of another paper here in the audience today, Ariel Winter. Ariel, right here, who is from the Medicare Payment Advisory Commission, who was a co-author with Nancy Ray, a principal policy analyst at MedPAC, of a paper on paying accurately for imaging services in Medicare and some of the complex issues therein. And perhaps, Ariel, you'll care to comment in our Q&A session. Any other authors who've wandered in off the street today? Okay. Anyway, yes. Elizabeth Wood, who's the author of the Dwindling Supply of Hospital Beds piece. Terrific. Thank you for joining us. I also want to commend to your attention our second report from the field piece that appears in this issue. This is a series that we are carrying out with under the partnership agreement we have with the Kaiser Family Foundation. And in this issue, Julie Appleby of USA Today has written for us on the controversy over CT angiography, another case study of the debate underway about imaging. In that piece, it underscores a point that actually, Lauren, I'd like to have you address, which is in the argument that took place between Medicare and essentially cardiologists about the value of CT angiography. One of the issues, of course, was that many physicians have invested in this equipment themselves. And as Uwe Reinhardt once famously said, there are lots of things that physicians can do for their patients and still be right with God. And one of them is to provide additional information to them, as you said, that may provide enormous relief. No, I don't have a terrible developing heart condition that necessitates catheterization, et cetera. That's obviously of great value to the patient to know that. It's also of great value of the doctor sometimes to perform that test and pocket the payment from it. So as we wade into this issue of the value of imaging that you described, where we really lack sufficient information, what do we know now about the role of financial interest in the imaging growth?
It's in some ways a great and very timely question. I know a lot of folks have been interested in this, and Medicare and other policy organizations and payers are quite interested in these questions. There certainly is a lot of evidence that goes back a long ways that seems to suggest that financial incentives for physicians can be important. There are some papers that are using older data, largely data from the 1980s and maybe some of the early 1990s, that suggest that doctors who own imaging equipment in their offices prescribe imaging or refer their patients for imaging tests much more frequently than physicians who don't own the imaging equipment. Some of the estimates from those studies are on the order of 3 to 4 times as often. I have some worries about some of those studies, and we've done some of our own work on these issues as well. One of the issues that comes up when you try to evaluate that information is whether doctors who buy imaging equipment are just different in their interest in imaging and their propensity to refer for imaging than doctors who don't. And so comparing between the two groups could maybe lead you to overstate the effect. We've done some of our own work on some of these questions lately, and tend to find that if you compare physicians before and after they acquire imaging equipment, there is an increase that's associated with acquiring the imaging equipment, but it's usually on the order of maybe 20% or something like that. So there will be a little bit of an increase that's associated with that. In some ways that makes sense. It's hard for, I think, physicians to dramatically change their behavior with respect to their patients. It would be surprising to me if people doubled or tripled or quadrupled their referrals for imaging just as a cognitive matter for physicians in the care of their patients. And so some increase is sort of logical to me, and it does fit with the patterns that we see in the more recent data. So I agree. I think it's important. It's been one of the largest components of growth in imaging equipment over the last, say, 10 years, maybe 5 or 10 years, physician office acquisition. And so it's an area where there's been a lot of pressure for more utilization, and I think it does bump up our utilization to some extent.
And yet we also have a paper in this issue that looked at the growth of imaging at group health in Washington State, and where there are no explicit financial incentives in that organization for physicians to use more imaging, and yet it's growing there as well. So how do we begin to disentangle all of this?
Disentangling it in a precise way is something that we'll probably never actually get to the bottom of. As we put in more imaging equipment, as we start to understand how we can use it in different patient groups and patient populations, there is a there has been and there probably will continue to be a trend toward more utilization. Physicians are learning how to use this equipment, and they're interested in using it, and in some cases discovering new ways to make patients better off. As that happens anywhere, even where there isn't financial incentives, we'll see utilization increase and we'll see changes. Some of that will be driven by good information. Some of it will be driven by a general feeling that we should be doing imaging more often, that you get from communicating, physicians might get from communicating with their colleagues in the absence of information. And I think that's one of the great challenges. Financial incentives for physicians are probably one part of the question. I think more fundamentally the question is, or the issues are being driven by, the utilization is being driven by the fact that we put in more and more of this equipment. Once we put the equipment in, we find ways to use it. Finding ways to use it is sometimes beneficial for patients, and in other cases maybe less clearly so. And so really the issue is, I think, more how we manage how much of this stuff we put in, how we manage what we do with it once we put it in. And some of that's financial incentives, and a lot of it is just the notion of the system changing and how we manage changes in the system, how we manage the fact that these pieces of equipment are available everywhere and relatively easily for patients, but relatively costly in a relatively costly basis for society.
So what should we do? There are as many MRI machines in Massachusetts as there are now in all of Canada.
Right. So one of the things that we might have done was manage how many of these things are out there. We did not do that. I don't know that we will be positioned as a healthcare system to do that. But if you look at other countries, and maybe group health is an example of systems within the United States that manage utilization effectively, or at least create structures in which one can have more focused discussions about the benefits. Those are structures and systems in which there is simply less of the equipment available. And so we might have done that. We have not done that. With it available very regularly, very easily, in a lot of circumstances, it becomes very difficult to say to someone who knows there's an MRI machine right next door that they can't have an MRI scan, to a physician who'd like to use it, that they can't do it. How do we start to think about that? I think the trends in the marketplace give us some indication of things that might work, or that people think might work. Trying to do more credentialing, trying to do more referral management, some of the kinds of things that are going on with the radiology management associations and organizations that private payers are using, I think is probably the easiest way to start to go about it, and maybe the only way we can make inroads into this, given that we've gotten so much of this available. I think going forward we ought to think about how much we have and how many folks we're willing to pay to do this kind of thing. And maybe we need to be more aggressive with payment policies and other things to try to get patients and physicians to understand the cost of what they're using when they use a lot of advanced imaging quickly. But that'll be a difficult discussion to have.
Okay, well, thank you. Well, to move over to the whole area of devices, Hal, basically, as I took your point, it was that transparency in the device sector would not produce any benefits, and the potential harm is that it could induce collusion, which would have the opposite effect on prices. And that the main thing that hospitals should do if they really are angry about the prices they're getting is to get a better group purchasing organization, because you seem to suggest that some GPOs are doing a better job of others and getting lower prices for the hospitals in the organization. Is that the takeaway then, that the best hope that these hospitals have of getting better prices is that, as opposed to price transparency? And then, Jeff, I'd like to hear your views on that as well.
Wow, no one's asked me until now what I think hospitals should do. So this is just kind of off the cuff. I was asked to respond to what I thought about mandatory price transparency. Well, certainly you can join a GPO. I don't know if some GPOs are doing better than others. Another way to get your price down is to commit to purchasing more of the devices from the preferred vendor. These are these bundled rebates that you can take advantage of. There's also loyalty rebates, which is, if you commit to buying a certain percentage of the device from the maker, you'll get an even lower price. Hospitals can form into these things called IDNs, distribution networks that serve largely the same role as GPOs, and that is they're collective. They consolidate the buying power of a lot of hospitals to try to drive down the price of the devices.
What would be the harm of, say, having price disclosure and then seeing what happened? You mentioned the case where FCC stepped in when it was clear that there was price collusion and stopped it. Why not just try it and see if it works? I mean, don't economists always like more information than less in markets?
Well, clearly this is a case where that's not true, right? I mean, if the problem here is that you are not only arming the buyers, in this case hospitals, which aren't really the ones who are imposing the price discipline, in my opinion, but you're also arming the suppliers with information that they do not currently have. Jeff said something at the beginning that I guess I just fundamentally disagree with. The bidding process is very secretive. And from my understanding, the rivals do not know each other's bids, and so you're actually giving them information that they could use in a potentially destructive way.
Jeff, do you want to respond?
Sure. Well, first on the overall point about buying through GPOs, keep in mind several things. Most hospitals belong to several GPOs, not one. GPOs are notoriously ineffective at both purchasing or setting up contracts for physician preference items. That's why it's one of the issues they got in trouble with in Congress because of their lack of effectiveness. So those are some key background points. Now, since a lot of people in hospitals don't use the GPO contracts for these purchases, because there's loyalty directly between the physicians and the companies. And that's a much more powerful force than the GPO contracts. So essentially, I wouldn't say completely irrelevant about the GPO contracts, but it sure ain't much. They could do a lot better job, but they can't. And the GPOs themselves are also subject to the same confidentiality clauses that other third parties
So one
are.
GPO can't tell another GPO what kind of prices it's got?
No, they can't. And they also can't collect the information from their hospitals to get that kind of feedback about where to set the contract price. A hospital has to decide, do I want to use the GPO contract or not? Well, why should they if they can get a better price without the GPO contract?
Hal?
Yeah, I just want to make it real clear that the GPO doesn't need to reach out to other GPOs to find out what the bids are. The GPO opens up a bidding process. These processes are rebid about every 3 to 5 years. They invite all the suppliers to come to the table, and the suppliers put down their chips and show what their prices are. So the notion that mandatory price disclosure for the hospitals is going to do something to affect that process just doesn't make sense to me. I'll also just remind Jeff it is true that some hospitals buy off contract, but this statistic just can't be avoided. Over 80% of acute care medical devices are bought pursuant to GPO contracts. So yes, it's true that there are some hospitals that go off contract, and as Jeff said, if they go off, it's usually to improve their prices, not to pay more.
Well, another question that's worth asking is some of these contracts have provisions in them where the hospital cannot tell the physicians in the hospital what prices it paid for contracts. Now, what is the point of that? Isn't it a good idea in general, even if we want physicians to basically be making decisions in the patient's best interests, shouldn't physicians also have the ability to take price into account and say, well, I'm not sure that this is worth the additional cost to have this device. And by the way, maybe as a doc, I have some responsibility for medical spending in society, and I ought to be thinking about this in the recommendations I make to my patients.
The physicians, let's agree on something, which is that the physician's preferences or taste for expensive things or insensitivity to high prices is certainly not helping things. That is a contribution to higher prices, all things equal. But that inflationary effect is not going to be addressed by mandatory price disclosure. The incentives are still wrong. This is what an economist would call an agency problem. That the doctor is pursuing his or her own interest for brand loyalty, and the healthcare purchasers, the product purchasers, some of whom I've spoken to, they're butting heads over what to buy. And no amount of disclosure by itself is going to change those incentives. Now, Burns and Pauly mention an idea about gain sharing and talk about how you address the incentives of the doctors to start being concerned about the prices. And that's a different debate. But certainly the debate that I've at least been asked to weigh in on, which is mandatory price disclosure, is that going to change the incentives of the doctors? No. They already know that they're spending like mad.
David, let's talk a bit about how the industry is now looking at all of this. Obviously, the industry has had an interest in not having broader price transparency, or at least that appears to be the case. But as with the pharmaceutical industry, it apparently does also recognize that the world is changing. Things are moving in the direction of greater transparency. So where is the industry at this point?
Well, I would say, on the narrow issue of price transparency, the industry is right where I said it was. We don't think there's a need for it. We think it's potentially harmful based on Hal's analysis, and it's sort of picking out a non-problem to have a major policy solution to. As I say, when our prices are going up more slowly than the CPI, it's hard to say you don't have a pretty well-functioning market already in medical device prices. Now, on the much broader question of how do you deal with healthcare cost control, I think there's no question that we're going to see changes in the healthcare system, which we support, incidentally, movements toward pay-for-performance, toward greater transparency of bundles of services, not individual components of services, toward incentives for doctors and hospitals to look at both the value and the cost of care, the quality and the cost of care. All of those things will have an impact on our industry in significant ways. But we don't feel that the right way to deal with the cost problem is to set up either this, what I think is really, as I say, an extremely minor issue in the whole spectrum of things, no matter how wrong-headed, on price transparency, nor do we think the way to solve the problem is to go after a kind of a nice, like one-by-one evaluation and setting up barriers.
Nice being the UK entity.
Gatekeeper as to whether or not people in the United Kingdom have access to advanced technology, drugs, and devices. We think that's the wrong way to go because of its potential, both because of its direct impact on patients for technologies that exist, but even more so for its impact on the likelihood of new and more advanced technologies being developed that can make such a contribution to solving these health problems that face millions of people. So we're in a position where we understand reform is necessary, and we indeed support reform to deal with the cost problem. But the issue is, what kind of reform do you support? One that's constructive and is going to make people better off, or one that in our view is destructive?
Jeff, you are raising your eyebrows. What is behind that?
Well, I think there are several points. First of all, there's a data issue. David showed, a slide that shows there's no cost increases from a study that Guy King did that was funded by AdvaMed. But the CBO is saying that half the cost increase is due to medical technology. So I think we need some reconciliation about what it is we're talking about.
I'd be happy to reconcile those, if I may. Sure. First of all, I don't agree with the 50% figure. I'm happy to do a long dissertation as to why that's a mistaken figure. But that figure has absolutely nothing to do with the prices charged for medical devices. That's the cost of technology writ large, which is technology for devices, drugs, new procedures of all kinds, yes. And the vast share of that increase is volume. It has nothing to do with price. Certainly in the case of our industry, as these statistics, which are drawn from the BLS and assembled by an extremely reputable researcher, demonstrate.
Right. Now, I do think that volume is linked to price, because the point is that if you're making a profit, a certain amount of profit, and you increase the volume, you make more profit. Now, if you look at some of these PPI devices and some of the actual facts and figures, they are the volume being purchased by Medicare and by the private sector is much larger than was originally projected. And you have to look at figures also that go after the 2004 dates that this Guy King study deals with. So there are many technical disputes we could have. I guess this isn't exactly the forum for them. But to say that these things are not a problem, this is a non-problem, is to ask you to go back and, just say, well, I guess there's no problem. And you have to ask yourself whether that's a plausible scenario. Now, you can bring down the costs by negotiating, and you know that. You know that in your everyday life. So I think that to some degree we're placing theory above the everyday experience you have. I also think that some of the arguments that were made are really not correct. You know, the Specter-Grassley bill does bundle in the costs of the rebates, all of the discounts, all of the free goods. And before, that point was rather glossed over, because in fact you can start to get a handle on those. You can't possibly negotiate around those or know the size of them if you don't actually track this. So I think we do need better data all around. I grant you that it's difficult in this area. But to not propose a solution, to only say, well, okay, I don't like this, and therefore healthcare costs are not a problem, I just find that implausible.
Well, as David says, we know there's a problem, and in fact, of course, we've published work showing that if health expenditures continue to grow at 2 percentage points a year faster than the gross domestic product, 122% of national income between now and 2075 will go to health care, which of course cannot happen because you cannot spend 122% of anything on anything. So we know, as Herb Stein always said, those things that cannot go on forever will stop. So we know this will stop, this excessive cost growth that is somehow related to technology. So I guess the question to tee up for all of you is, so what do we do that would have some buy-in from a public that wants a lot of care, physicians and others who want to make more money off of health care and do the right thing by patients, incidentally, people who increasingly do value information, just the way we value improvements in other things in society, no matter how marginal they may be. How do we get out of this? Lauren.
Oh, goodness, going first on a panel of experts like this. Well, I think we need to do two things. One thing we need to do is we need to look forward at thinking about how we make decisions about availability. Now, we talked a little bit about NICE. Other countries have thought about processes by which we can evaluate new pieces of equipment and new procedures and new ideas that come along. And we have really not done that very effectively. We've essentially leaned on the marketplace and the information flows in the marketplace to manage the availability of equipment and the kinds of services we have out there. And those have produced a rapid proliferation of lots of things that are very interesting to patients, often good for patients, but very expensive. And the real question going forward is whether we think the market can effectively navigate increasing cost challenges and produce efficient, really, availability outcomes. And I think there's some reason to wonder about that, particularly in the absence of good data on effectiveness. And so ultimately, I think we need to create probably better information structures for understanding effectiveness, for trying to make decisions, make information available. Whether that can ultimately be just incorporated into the systems that we have now, or whether we need to maybe take a little bit more an aggressive role with managing how fast new things roll out, or how we gather the information as new things roll out, I think is an interesting question. But I would be, from my own view, open to considering maybe other structures and more aggressive structures in that direction. I think that's where healthcare costs probably are ultimately going to have to be managed if we're really going to manage them. In the short run, we have to do things probably with payments and coverage for the things that we have out there to try to make sure we're being efficient and effective. And some of that's also comparative effectiveness research. Some of that is maybe other policy matters associated with requiring payments from patients for some of the services that look more elective than we might have than things we might have covered more in the past. And so I'm certainly also interested in opportunities for changes in coverage and changes in physician and patient cost sharing for some kinds of procedures, because that's probably where we can make more efficient decisions within the structures that we have now.
Lauren, you and Hal both mentioned NICE, which I believe is the acronym for National Institute for Clinical Effectiveness in the UK. And of course, David, many people, pharmaceutical manufacturers, others think that NICE is not so nice, that basically it has kept off the market drugs and other things that are of great value to people. What is AdvaMed's sense of the viability or the advisability of creating a NICE-like entity here in the United States?
Well, first of all, NICE in the UK, actually, from the medical device perspective, hasn't been all that bad because what you're there operating there is under a fixed budget. And in some ways, NICE makes it possible to get more expensive but valuable products on the market that might not otherwise be incorporated by the local health authorities. In the United States, I think it's a terrible idea, not just for the United States, but for the whole world. Because what NICE does essentially is to take an arbitrary cutoff for the value of a quality of life year gained and say if your product or a product does not exceed that value, then you can't sell it, can't be distributed. It's a sort of an additional tier of evidence required before a new product can be distributed. The impact of that is often quite devastating on patients. You know, you until very recently, you could not get any MS drugs in the UK because NICE found none of them to be cost effective. You still can't get drugs for liver cancer and other cancers where they have a definite impact on improving life expectancy and quality of life, but they don't meet this arbitrary $60,000 per quality year of life adjusted cutoff. In the broader sense, you know, what setting up those additional barriers to getting things on the market does is to really inhibit the development of them in the first place. Because if you're thinking about how to develop a new device or a biotech product, I mean, typically the really breakthrough stuff starts with venture capital funding of very small firms. They have to get to proof of concept. Then, if the proof of concept is robust enough, they get picked up by a larger firm, which will then take it to the marketing stage. When venture capitalists or our companies look at developing a product, they look very much at sort of the expected return against the cost in what's inherently in a highly uncertain environment because you don't know whether the thing's going to prove out medically. You add an additional barrier, having to show cost effectiveness before you can get the thing on the market. You're going to inhibit both the flow of funds that develops the stuff in the first place, and you're going to delay for an extended, because it's going to raise the cost and time involved to get the thing to the market, and you're going to delay for an extended period things that are very valuable getting to people who will suffer and die as a result. So I think it would be a very negative thing in the U.S. Moreover, there's no evidence that NICE or any of these kind of systems really make a significant difference in the cost of the overall healthcare system. There's an awful lot going on in healthcare besides sort of one-by-one screenings of new technologies, and I think that really the kinds of things that are laid out in the presidential campaigns of both parties are going to have a much bigger and quicker impact on our health system in a way that's positive for patients than doing something like NICE. I'm talking about things like prevention to reduce growth in obesity, which seems to have been responsible for certainly 12% and perhaps as much as 28% of our growth in healthcare costs over the last 20 years. About the incentive system, which reward doctors for doing more, not for doing doctors in hospitals for doing more, not for doing better. The lack of transparency, not on medical device prices, but on quality and cost of care that for both payers and patients. I mean, there's a whole set of things, the incentives in the whole system. There's the organization of care so that you can manage chronic disease better, which is implicated in 80% of healthcare costs. There's a whole set of things that we can do and should be doing that don't inhibit our ability to get the cures of tomorrow. That seems to me the solution to what's clearly a problem. But the problem is not medical device prices. It simply isn't.
Let's open this up to a question and discussion from all of you. And I want to just ask Ariel if he wants to make some comments for starters. No? Okay, you're going to pass on this. Okay. And if you would identify yourself by name and affiliation, we'd be very grateful. Do we have microphones here as well? Yes, we do. Okay, let's get a microphone up front here for our first questioner. Thank you.
Bob Griss with the Institute of Social Medicine and Community Health. The focus has been primarily on the price of equipment rather than the intensity of use of that equipment. And Laurence has mentioned the word availability, which has to do with the supply of the equipment, the medical arms race that occurs when hospitals decide to purchase equipment that is really duplicative of other equipment already in the community. We have used certificate of need processes in this country before to deal with this problem, but not totally successfully. I'm wondering what solutions there are to effective certificate of need processes to make sure that equipment is not inappropriately used and inefficiently used within a geographical area.
Would any of you say that any state in the union has an effective certificate of need process currently underway? Lauren?
Any state in the union with any success. I think there have been cases where certificate of need has shown some impact, and there are states that have been more aggressive with their policies than others. It has a history of being easily circumvented politically. It has a history of not always keeping up with changes in technology, and so there are clearly problems with using any sort of broad regulatory process like that. But I would say that it's possible that there are examples of states that have managed imaging growth differently than other states, and so there are some examples one could point to. Whether we think they're ultimately great for society or just blunt instruments that had some impact or not is a more debatable point. More generally, I think there are important questions that come out when you start to ask about this, which is. One approach is to not try comparative effectiveness research. One approach is to not try NICE-like evaluation of new technologies and simply let people put in whatever pieces of equipment they want. Once pieces of equipment get put in, they almost invariably are used. And the kinds of pressures to use new pieces of equipment can create circumstances in which we worry a lot about financial incentives driving utilization, in which we worry about the ability of folks to understand the cost and benefits of the decisions that they're making to put these things into place. And so ultimately, I think we have to start to think along the lines of the question, whether we go back to old CON-type processes, whether we try to build new information-gathering processes. We have to do something. To simply argue that we shouldn't be gathering this information, we shouldn't be trying to use it, is to, I think, ignore the history of the rapid growth and availability of pieces of equipment that have been driving lots of pieces of equipment. So I think that's important.
An approach that Medicare has tried is coverage with evidence development, although even in the case of CT angiography, it was not able to get that through. Jeff, do you want to say a word about that process and the advisability of putting some hope in that approach?
I put hope in every new approach that we keep trying for two reasons. One is that I think that intellectually we do advance, and the kind of coverage that Medicare was offering before coverage with evidence development is, to me, a blunter instrument. So, I do like the idea of trying to get technologies on the market where they really do look promising. It has, of course, the problem of what do you do once things are around, even without evidence, because people do use them, and the kind of evidence standards people sometimes have are, I think it'll work for me. So that's kind of a problem. One comment on CON, though, to go back to that just for a moment. One of the great things it did have that I think got lost was that a lot of the decision-making was much more local. You had health systems agencies, and you could do some of the work that we're talking about cost effectiveness, how much does a community really need something, at that level, not just at a large national level, the way you're talking about at Medicare.
So some hope for smaller certificate of need approaches, although Maine, for example, has tried that in the context of its recent health reforms to not particular avail.
Yeah.
Yep. Yes, a question here.
Hi, Sean Rhea from Modern Healthcare. I have two very quick questions. I need clarification on a couple of points. First, for Hal Singer. Hal, you mentioned that about 80% of medical devices purchased by hospitals are done through GPOs, and all of my conversations indicate very differently, so I was wondering if you could tell us where that data came from. The second is for Jeff. Jeff, you mentioned that quite often it's not volume purchasing that actually secures best pricing. I want to know what those other influences are, other than purchasing large amounts that will influence.
Hal?
Sure. And I don't know if I'm going to be able to call the citation up off the top of my head, but it will be cited in the article. And there's just been a ton of papers written on GPOs and the GPO process. I know that 80% is even a lower number than the percentage of hospitals who actually belong to a GPO. I think that's somewhere in the 90s. But my recollection is that somewhere around 80% of all acute care Now, this is important. Acute care medical devices get purchased pursuant to a GPO contract.
But then those would not necessarily be physician preference items, and those seem to be the big issue in terms of cost, from what I understand.
Well, now the question comes to what's the overlap between physician preference items and acute care, right? And so, to the extent that they overlap, then these are being bought pursuant to a GPO contract.
And the second question, Jeff.
Okay, you're asking me about what are the other influences besides volume, but you want those influences to be on what gets purchased? I want to make sure I answer your question properly.
You mentioned that volume purchasing does not always influence what gets purchased, and I'm assuming meaning pricing, the price.
The price is what I'm saying.
And so I'm wondering what those other influences are on how much hospitals actually pay for the items that they're purchasing, other than volume.
Sure. Well, some of the things are the free goods and services that are provided by manufacturers that they go into the calculation, along with things like rebates and so on. Now, in that Grassley Specter bill, they actually laid out, in at least broad terms, what they think are some of those other issues influencing the
Aren't there
price.
sort of frequent flyer type arrangements
Yes,
in
there
many of these contracts? The more you buy from us, the better deal you get, Hal?
Right, those are the loyalty rebates. So if you commit to buying a certain percentage of this device from the supplier, you'll get a lower price, all things equal.
And it is a complicated business because people do develop these loyalties, which are both good and bad, depending on the circumstances. You would want a surgeon doing a very delicate operation to be comfortable with the technology they're using, especially if they're using it on you. But on the other hand, some of these loyalties are really created more through traditional and long-standing relationships and don't really have that kind of basis in technique. So it's a mixed bag.
Let's take a question here. Joel.
Joel Coopersmith from the VA. I have one comment, one question on cost effectiveness, and I think it was mentioned in one of the articles in this issue. Early in the phase of technological development, it's probably not all that valuable, and particularly for something like defibrillators, it would have thrown people off tremendously. My question is related to the comment about venture capital. This is probably, I'm not an economist, I'm a physician, but I imagine this is one of the more fragile areas for venture capital, and it does seem like there'll be a lot less of that money around in the future. Would anybody want to venture any predictions as to how that's going to affect this?
Anybody with your finger on the pulse of the VC market?
Again,
David?
As I think I mentioned earlier, at least in our industry, and I think this is true for biotech as well, a lot of the truly breakthrough products do originate with venture capital funding. They put money into a very high-risk venture. It's really just an idea in somebody's head. And it's very sensitive to changes in the environment, either the reimbursement environment or the regulatory environment. So when the Clinton administration put forward the Health Security Act, and some of the original versions, they had I've forgotten the details of it, but it was viewed as a price regime that was viewed as very negative to the biotech companies, and venture capital investment in those firms just dried up that year. And I think that's, in a general sense, as we look at payment reforms, which we need to promote efficiency and effectiveness in the healthcare system, we have to be very conscious of their potential impact on innovation, and particularly things to try and screen stuff out early or raise the burden of proof in the early stages of the development and adoption of the product will have a very negative impact.
Questions here? Yes, please.
Don Rucker. So my disclaimer is I work for Siemens and we make CT and MR, and I'm also an ER doc. For Dr. Baker, a comment and a question. The time period you picked there, sort of 95 to 2004, 2005, and your explanation of the growth, I think there's a very different explanation of growth, which is there's been a Moore's Law effect. So in 95, you went from exploratory surgery, right? So if you came to an ER with abdominal pain, they admitted you to the hospital and they watched, and then with a allowed for by the best surgeons 20 or 30% error rate. So open you up, take a look, only 20% wrong, fine. So they went from eliminating exploratory surgery as they got rid of respiratory gating 95. By 2000, basically we got rid of VQ scans, which were sort of like reading entrails to give blood thinners for anybody who ever had to read that or do pioped studies. So we got rid of that as Moore's law allowed resolution of the pulmonary arteries. And then at the end of the period, as the scanners, again with Moore's law, got so fast that you could stop a heartbeat and look at coronaries, we're on the way to eliminating, stress tests and all kinds of expensive things there. So I would just throw out that there's a very different explanation than moral hazard for your growth curve, especially particularly the years you picked. And then then the question is on your categories where you had medical outcomes and then the sort of information value, so as was put, you're not going to die. What about substitution effects on other diagnostic costs? So days in hospital, other studies, repeat ER visits. I know that's very hard to look at. It's a bigger problem for Medicare with episode grouping. Just curious for your thoughts.
So a couple of things. Absolutely. There have been dramatic improvements in the technology and the ability to use the technologies, the imaging technologies, to do really beneficial things for patients. I absolutely agree. And I think, as we were talking a little bit about, there's been a generic increase in utilization, even in systems that don't have any financial incentive, that really aren't looking like some of the places where you might worry that someone's got a financial incentive to do some more procedures. And I think a lot of that is driven by better scanners. I think it's driven by better understanding of how to use them. And so as we put in more of these pieces of equipment, we do get some opportunities for improving patient outcomes. I think you could also, at the same time, still worry that as we put these things in, we don't really know how many we needed to put in to get those benefits. We've put in 3,000, 4,000 CT scanners over time. We put in maybe 3,000 MR scanners over time. And so some of those are clearly associated with creating great benefits, but I'm not sure we know every time that we put one of these things in, especially in some cases where we've got loads of them around in an area already, that we're always at the margin where we're going to be doing the substitution that you exactly talked about. And I think that's the great challenge. It's a challenge that's a hard one because, of course, we often get benefits from these kinds of procedures, and we want to not lose the opportunity to get them. We also want to create opportunities, though, to be efficient about utilization and to think about it, and some of that's information and other things that will help us do that. You also were asking...
The issue about broader costs, not just looking at what's spent on imaging, but do you get benefits out of reduced hospital stays?
Yes.
The larger impact on the system.
Yes, and I think that's a very interesting question, and we've done some looking at that in our own work. What happens as soon as you try to look at that from an analytic standpoint is you get pushed back to think about particular circumstances for particular patients. So a patient with, in the Health Affairs article here, a potential abdominal aortic aneurysm is a particular type of patient, and there is a CT imaging that we can use to look at that, and there are other diagnostic tests that might be the older version of looking at that. When you start to think about different patients, you might think about different issues. But I'll tell you what we found when we looked at the CTA for abdominal aortic aneurysm, and similarly in another paper, what happens when we look at CTA for carotid artery kinds of problems where you get opportunities for substitution. As you expand the availability of imaging, you do see some substitution. So you see some substitution from catheter-based studies of the arteries, which can have some side effects, which maybe a couple of % side effect rates. And so you can substitute a CT procedure with essentially no side effect rate, net of some radiation that you're going to expose the patient to, for a procedure with some side effect rate. Maybe if for 100 new CTAs that we see done, about 15 patients are substitutes. That is, patients who would have gotten the old catheter angiography test for an abdominal aortic aneurysm now are getting this better non-invasive procedure, which would have some benefits. About 15 more patients of the 100 that got new CTAs are patients who now get both. So we don't actually substitute away. We do one and then we do the other, and that will probably create some information for patients. It might create other therapeutic benefits, but it's a little less clear to think that we're substituting away from a side effect-prone procedure. And about 60 or so, 65, actually I think it's 68, I'm trying to recall the numbers off the top of my head, about 68 of the patients getting the new CTAs are patients who would have gotten no diagnostic testing before. That is, they come into a doctor's office or an emergency room, they say something that makes someone think, well, I better check for a CT, for an aneurysm. In the past, maybe a physician would have said it's probably not, so we're just not going to do anything about it, and we're going to hope for the best, and probably that mostly worked. But now a bunch of the patients are going to get a test, and they're going to get some information from that test. Most of the time, it looks to us like all that does is rule out an aneurysm. Ruling out an aneurysm is good because it tells you that something terrible isn't about to happen to you. But only in about 1% of those cases do you actually see a new therapeutic procedure. So that screening, if you will, is not finding that much disease. And then you get into some of these arguments that we talked about. The value of the information is something for patients. It's useful for the patient's well-being. It's useful for treatment patterns. It does lead in some cases to some better therapy, which would have big measurable impacts for the treatment of a disease that could be fatal, is often fatal for patients. So there's some real value there.
But it doesn't sound like
it
doesn't sound like one can discern a whole lot of impact on the broader healthcare system from any of that.
But exactly. So you end up with this case where there's a big benefit for a couple of patients and some information for a lot of other patients, and it becomes very hard to understand how we want to make a cost-benefit trade-off in that case. And it becomes quite easy to argue that maybe to at least worry that maybe we're doing a lot of screening that's very costly that we ought to be thinking very carefully about. And so I'll answer your question that way. With reference to that particular condition, maybe you'd have other examples where it would be more favorable one way or the other, and people will argue in different conditions.
So it's very clear, in other words. Bottom line is very clear.
Hi, Alwyn Castle with the Center for Studying Health System Change, and I have kind of a global question that I think gets at both, price transparency and, increases in technology. I think oftentimes when we have these conversations about technology being a major driver of increased per capita healthcare spending, we get bogged down just on the price piece, and I think we've talked about a little bit that it's really the utilization that is where the power is. You get a new piece of technology, it's designed for a group of patients, it ends up being used far more broadly and diffusing far more rapidly, and we do not have any real checks and balances in this country on that. So moving away from disclosing price, I'm interested in whether or not the device and drug and all of the technology manufacturers, rather than disclosing prices, would be willing to disclose the incentives that they use with physicians to induce them to use all of this stuff, which is perhaps a bit more complicated. But and looking at the device and the implantable devices in particular, I mean, there's a real disconnect here. Doctors choose which device they're going to use. The hospitals have no control over it. There are all these kinds of incentives going on in the background to influence the physician choice of device. It's like saying, okay, I'm going to go buy a Cadillac. I choose a Cadillac. You're going to pay for it. There's no incentive for me to be cost conscious. The advances are often minimal in the technology.
And as we've said, in many cases, the doctors aren't even allowed to know what the price is in the first place.
Well, but I guess I'm speaking more directly to the overt incentives. I mean, with some of the imaging equipment and some of the drugs and all of this stuff, I mean, part of the marketing strategy of the manufacturers is to go in with a presentation to the docs and say, look, buy a CT scanner. It's like putting an ATM in your office.
Right.
How about disclosure of those things rather than price?
David?
Well, we support payment disclosure by manufacturers and physicians. We have a code of conduct, which we're updating, which is there's pretty rigorous rules for what is appropriate and inappropriate payments to physicians, and we support the sort of a modified version of the Grassley-Cole bill, which would make disclosure of payments to physicians mandatory. I think that should be in the public domain, and we're opposed to any unethical or inappropriate relationships. I do think people need to understand, though, that not every payment that a medical device manufacturer makes to a physician is an inappropriate payment. the device industry particularly, more so than I think some of the other fields, relies very heavily on collaboration between manufacturers and physicians for a couple of reasons. First of all, a lot of the inventors of the devices are physicians. They're very involved in the developmental process, and so obviously need recompense for that kind of activity. And second, you can't use a lot of the devices. There's a heavy element of physician skill in a lot of devices, so that there needs to be an important training role, which often the manufacturers are best equipped to provide, particularly when it's a new device. So there are certainly appropriate financial relationships, but we believe they all should be disclosed.
And what about the programs that many manufacturers have in place to basically lend docs the money to buy the equipment? You can basically get a very detailed scheme. If you do this many scans, you will recoup this much in revenue. I mean, there's a whole supporting industry to enable people to buy more of this, which may get us into the situation that Lauren talked about. What do we do about that?
Well, there have been some abuses in these kind of lease purchase arrangements, which actually have been, I don't think that they're a major part of the business, and they've been, the new inpatient enrollment, I understand, has outlawed some of the ones that were thought to be abusive, but it's certainly, when you're talking about big ticket items like an imaging machine, which may be millions of dollars, it's certainly not inappropriate for the manufacturer to work with customers on a financing arrangement per se. I mean, obviously you have to look at it, but the issue is if the financing arrangements don't make sense, from the public's point of view. I mean, they don't. To have them be inappropriate from the public's point of view, the payment for the service has to be inappropriate. And certainly there's a strong interest in making sure that payments are accurate. Medicare has made a number of significant reforms in the last couple of years to try and make that be the case, and we support accurate payments. I mean, people ought to be paid the reasonable cost of their products, but they shouldn't be paid unreasonably.
Jeff, do you have any thoughts about that?
Well, it does. In general, I do agree. I mean, I think that medical technology is a wonderful thing, and it does need to be used appropriately. And we've, covered a lot of ground about ways that it could be. Now, I still, come back to the original purpose of why I was asked to talk, which was on price transparency, and I do think that's an important part. If you want to determine cost effectiveness at a local level, well, then you need to know what you paid. So I really wouldn't be so dismissive of the idea that knowing what you pay makes sense, knowing what comes in those packages makes sense, and getting a lower price makes sense.
Let's take just a couple more questions here. One here. Actually, let me take one behind you, if I might, and then we'll come back to you.
Hi, I'm Dr. Rose, the president and CEO of Vicro, which is a company that works with the healthcare industry during their development phase of drugs, devices, etc. At a recent meeting of the Swedish American Life Sciences Summit, in which I gave a speech, I used a quote from Gruna Alvin, who is the director of the medical device area in Sweden. And he was applauding the innovative products that have come out in medical devices. At the same time, he said, what is lacking in research are the methods to determine where, when, and under what conditions to use those devices. And I wonder whether the panel here agrees that what is lacking are the methods, the research and the methods to determine the uses of these very innovative products, almost similar to the personalized medicine within the drugs.
And Bill, it sounds like right into the early trials of these products. David?
Well, I think there are two things. I mean, first of all, that clearly is terribly important, and as we move closer to personalized medicine, particularly with the development of molecular diagnostic tests, I think we'll be able to do a better job in both drug and device design from the beginning and tailoring the product to the needs of specific patients instead of broader groups of patients. That'll reduce the development costs, I think, and will also make the products more effective when they come out. Till we get to that stage, and it comes very slowly, I do think that there is a very strong public interest in finding more about what works best for whom and when. There's a major effort to establish more money in comparative effectiveness research in the United States with a new institute funded probably around $200 million a year. Our industry supports that effort. So we do think that more research is very desirable. There is a certain amount of things you learn by doing that, particularly until we get to the molecular basis of a lot of these things some of these things you learn not by formal studies necessarily, but by clinical experience, particularly since in our industry at least, the devices develop iteratively, so that it's hard to do an effectiveness study really has tremendous value often because the device is evolving so quickly that by the time you get the study done using conventional methods, the device is a different device than the one you started out to study. But even with those caveats, I think that the more we can do, the better. And we get new stuff every day indicating sort of better targeting of products, whether they're devices or drugs, which is terribly important for patients and I think for the public interest.
Lauren, what would we do on the imaging side that would be analogous to that?
Yeah, so I was going to add on to what David was saying, and maybe it goes to the imaging question too. I think we absolutely lack the information that we need. We try to use existing claims databases that are always a little bit out of date, even with some of the efforts to, say, do approval with effectiveness data. We would start to keep up with some of the things that are going on, but the market evolves very quickly. The devices and the imaging equipment evolves very quickly, but I think even more importantly, we evolve very quickly in terms of the patients, especially in imaging, in terms of the patients and the conditions and the circumstances in which we use equipment. And so there's always going to be this problem of knowing what was going on with the patients we were using this for last year, but now we've got some more ideas about who else we can use it for, and we're into a new patient group, and every few months we're into new diseases that we might be able to use this for, and somebody thinks of a new idea. And so we'll always play catch up with the data. And with imaging, I think that may be particularly acute, but I wouldn't be surprised if little thinking suggested it was also a problem for other types of devices and approaches also. So one of the things that I think we need to think about in tandem with collecting better information, which is clearly crucial for doing a good job of efficiency, is how we, and I'm going to tell you about a problem to which I have no solution, is how we think about a world in which we can't ever quite keep up with the data that we need, and we need to have other processes or structures or ways of thinking in place to manage how we don't to keep ourselves from getting so far behind the curve and always keeping up that we can effectively manage processes going forward. And I think that's very difficult. Some of that innovation is great. That's what creates great value for patients. It makes people better off. Some of the new ideas are the ones that are tomorrow's great blockbusters.
Does that up the ante on having patient registries that are broadly accessible, HIT, EMR systems, et cetera? I mean, is that a critical component of all of this?
Yes, it seems to me that we'll never, the closer we can get to having real-time information, the closer we can get to being quickly able to react when we have new ideas, the better off we are, and more computerized information is clearly a good thing in that direction. Will that ultimately solve the problem? I hope it would be a big part of solving a problem. We may still need to do other things to make it work, and maybe other folks have.
Hal, do you want to add anything to that?
Well, just the last two questions, I think, just teed up this point that there's something larger going on than information, and just adding more information to the process, which I in terms of its incremental value, I think is zero, isn't going to solve these incentive problems, these what an economist would call an agency problem. So you tell the doctor that you're spending exactly 36% higher by going this way, and he goes that way anyway. And now you tell him that, and somebody else, some other price over here is X. He still goes that way. That doesn't address the incentives. And so, to the extent there's an agency problem, mandating this disclosure of prices isn't going to address it.
All right, let's take a final question here, please.
Thanks. David, you started addressing the issue of vendor financing for capital purchases such as imaging equipment, and I'm wondering, given the financial atmosphere that we're living in, and given the fact that Senators Grassley and Cole are really taking a very broad look at all of these issues that are affecting pricing, do you think that the use of vendor financed or do you think that vendor financing is going to become an issue that they're going to look at more broadly? Because I understand that more and more hospitals are having a hard time getting funding for major capital purchases. So,
I don't think the question was originally about vendor financing and physician office. I think in terms of hospitals, I don't think people really see any conflict of interest between vendor financing and use of equipment. I mean, the hospitals obviously have a strong interest in keeping their costs down, and they're looking for the things they need to serve their patients at the lowest possible price, and they'll look at financing if they can't find it. If there's something that they feel they need and they can't finance it out of current revenues, they'll look for financing from whatever source they get, and if vendors can facilitate that, I think that's fine. The Grassley Cole bill looks exclusively at relationships between vendors and physicians, for the issues of agency, really, I think, that they have in mind that Hal mentioned.
All right, so the take-home message, I think, of today's briefing is that these technology issues with respect to healthcare involving difficult issues around markets, around information, around incentives, is a very, very, very complicated area indeed. So we know that, but we also know, again, to invoke Herb Stein, something that cannot go on forever will stop. That we simply cannot sustain this pace at these prices, and more importantly, this volume of spending on technology. At least we don't think we can. So if you each had to make one recommendation for one step, one important thing that could be done by the next administration, the next Congress, to begin to bring this down to a level of greater sustainability, what would it be? Lauren.
In short-term steps that can be done by an administration, I think we need to work on collecting more information and try to use the Medicare program as a lab, as a place in which we can start to evaluate how we pay for things and whether paying differently for things starts to matter. More broadly, I think it goes to a much longer set of things that are, in some sense, social debates and discussions we have to have about how we use things that are very expensive and how we evaluate and and what the public expects from the medical care system. But that's not something we can do in the next administration. So I'll start with more information.
Or at least finish.
Medicare.
At least finish. Jeff.
I guess if I could have my wish list, it would include broadening the types of research that we do about decision-making, how people really make decisions, which is only partly these technical issues of how well technologies work, and only partly these cost issues, these economic types of analyses. There are also some fundamentals about how human beings think and work, and while that is harder to grasp, there are other fields that inform our lives and inform healthcare, because after all, this is about preventing premature deaths or even death in general, and pain and so on, and those are complex.
So your recommendation is more research on behavioral economics. What is it?
It is partly bringing in behavioral economics, and it's not just the more research. It's using that research, actually starting to try to get people to put this stuff together intellectually. We may have a lot of what we need. I'm sure we don't have all. But when are we going to start to have a broader view?
Hal?
Yeah, my answer is going to be limited to constraining the prices of medical devices only. But here I think that we could use a little reform of the GPO process. I'm a big, of course, it's obvious, a fan of GPOs in general, but there are some abuses, and the abuses turn on these sole source contracts and higher administrative fees in response for sole source that have the effect sometimes of undermining competition. I've got a paper on that, and I think that is an issue that should be considered by the next Congress.
David.
Okay, well, I'd like to respond a little differently, because I think your question kind of conflated the issue, Susan, if I may say so, because I think that what is unsustainable is healthcare cost increases. It's not medical progress or rapid growth in medical technology. So my recommendation to the next administration, the single most important thing they can do to reduce the rate of healthcare cost increases is better management of chronic disease, which I think will boost some technologies and reduce the use of others, but it's not really a technology-focused solution to the cost problem.
Okay. Well, thank you very much, all of you, for a terrific discussion. Thank you for coming to our briefing. We'll see you at our next briefing in January as we unveil our forthcoming issue on chronic disease, speaking of the problem that David just put on the table. Enjoy the rest of your day. Thank you very much.